Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm happy to be with you today. This will be a brief lecture directed to the level of medical students, and what we will be discussing is the clinical approach to seizures and epilepsy in children. To start with, epilepsy is quite common. Actually, it's one of the most common neurological disorders, particularly in children. Therefore, it is a topic that a student should know quite well, both in the chronic phase, in the outpatient clinic setting, or in the emergency room setting when patients and children present with status epilepticus. So to start with, we will just go over some definitions. Of course, seizure is a transient neurological manifestation. So it can be any kind of neurological manifestation, such as motor, sensory, somatosensory, psychic, and so on, resulting from an abnormal transient electrical cortical discharge. So epilepsy is really, seizures are really an cortical phenomena. Epilepsy, on the other hand, is recurrent unprovoked seizures. So when patients have 2 or more seizures that are unprovoked, we call that epilepsy. And this takes us to provocations. So what do we mean by unprovoked seizures? Meaning seizures not related to transient problems or clinical situations such as fever, illness, vomiting, trauma, intoxication, and so on. So if the seizure occurs repeatedly with no clear transient trigger, we call that epilepsy. Just a short description of what is called convulsion, because we do come across this term, and in general the term convulsion should be reserved to children with motor seizures. So more typically generalized tonic-clonic convulsions. So we generally do not use that term when we refer to more partial seizures or sensory seizures and so forth. Once in a while we get asked about the term fit, and I think the term fit should not be used because it has a kind of a psychic implications. You may come across it, especially in some European references, but in general it's a term that should be replaced by seizures and epilepsy. Next, we will then move to the etiology, because we already alluded to the provocations, but of course provocations are not considered causes, because a person may be genetically predisposed to have epilepsy, and then when there is a trigger, he may be more likely to develop seizures. So in general, the etiologies are categorized into primary or secondary. So primary meaning that it is genetic or inherited, or the other term is functional. So it's a problem in function rather than a problem in structure. While secondary are generally the result of a secondary brain insult, such as post-traumatic, post-neoplastic, inflammatory, post-meningitis, post-encephalitis, and so forth. So think of the etiology. Of course, the more common is primary. So when we look at the children, up to 70% of children with epilepsy, we may not find an organic pathology. However, with the advances now of high-resolution MRI and functional mapping of the brain, this percentage is becoming smaller as we go along. Then we move to the classification. And from the medical student point of view, the classification is quite important. And in general, there are two classification schemes. One that deals with the classification of seizures, and the other one deals with the classification of epilepsy syndromes. So we start with the classification system of seizures, and this is of course based on the International League Against Epilepsy recommendations. So seizures are classified into either partial or generalized. And there is a third category which is unclassifiable. So if you're not sure, or the history and observation, you cannot really pinpoint whether it's partial or generalized. And partial simply means that it is focal or involve part of the brain, while generalized, it involves all the brain. So partial seizures are also subclassified into either simple partial, which is a focal seizure with retained awareness or no disruption whatsoever in the level of consciousness. While complex partial, you have disruption in the level of awareness. However, consciousness does not need to be lost completely. So the patient may still be aware, however, he might be confused or however, any disruption in the level of awareness will make the seizure complex. So in other words, simple partial seizures, the other term for it is really aura. So an aura by definition is a simple partial seizure, so the patient will feel it, will remember it, can describe it, so he's completely awake and alert. So an aura by definition is a simple partial seizure. The third category of the partial seizure is that a partial seizure can start simple, then evolve into complex. So you either have simple, complex, or simple that evolves into complex. And as I mentioned earlier, of course, these partial seizures, the manifestations depends on the region of the brain involved. So they can be motor, sensory, psychic, somatosensory, special sense, and so on. The other type in the classification is generalized, and generalized are also categorized into either primary generalized or secondary generalized. Primary generalized meaning that the seizure is generalized from the beginning. So there is no aura, the patient does not remember anything, and it is generally a genetic kind of disorder. Examples of that is myoclonus, absence seizures, drop attacks are examples of primary generalized. While secondarily generalized seizures are in fact more common, where the seizure starts as simple partial or complex partial, or simple partial that evolves to complex partial, and then the patient will have a generalized tonic-clonic seizure. So it is very important when one takes the history of such a patient. In any patient with generalized seizure, it's important to pinpoint or identify any focal onset, because that will help in classifying the seizure into either secondarily generalized or primary generalized. Next is the classification system of epilepsy syndromes, and I think this is important because many of our medical students, they get confused, and they use the syndromic terminology when they talk about the classification of seizures. So the classification of seizures is simple, straightforward, you understand it now. An epilepsy syndrome is relatively more complex. So when you have a syndrome, it is an epilepsy syndrome. So the patient will have seizures. However, it is a syndrome, so there is a constellation of clinical features that are associated, either at the level of the history, examination, investigations, EEG, imaging, outcome, and so on. So I'll just highlight it by giving the example of febrile seizures. So febrile seizures, there is an age of onset, it's benign, EEG normal, they require no treatment, the outcome is good. So this makes it a syndrome. At the same level, a patient with febrile seizures, he may have one or more than one seizure type. So he may have generalized tonic-clonic seizure, that is primary, or he may have partial seizures, the so-called atypical febrile seizures. So you could classify such a patient based on the seizure classification, and you could classify him based on the epilepsy syndrome. So the classification of epilepsy syndromes is generally subclassified into three categories, either idiopathic, and that is typically genetic. So the patient usually is neurologically and developmentally normal, so idiopathic. And then there is the type called symptomatic, which means you have an epilepsy syndrome secondary to an insult or a disease. So the epilepsy is a symptom of an underlying problem, such as tuberous sclerosis, a tumor, hypoxic, ischemic insult, and so on. The third category used to be called cryptogenic, and now it is called unknown, where the patient may be neurologically and developmentally abnormal. However, you really do not know the underlying cause. So the patient is not idiopathic because he's not neurologically and developmentally normal, and you cannot identify any underlying pathology. So this patient, we used to call it cryptogenic epilepsy syndrome, or now it is called unknown. Why do we care and why is it important? Because it does affect the outcome, prognosis, and response to treatment. So when you have an underlying cause, it is symptomatic, it depends on the cause itself. So if it is a lesion, the lesion can be removed and the patient may become seizure-free, such as cortical dysplasias, for example. The idiopathic types, some of them are benign and the patient may grow out of it. Some of them are lifelong. So it does provide some prognostication and counseling information. Finally, the unknown or the cryptogenic carries the worst prognosis because you do not know, the patient is not normal, and therefore you cannot provide much data, and they tend to have generally less favorable response to treatment. We then move to the clinical assessment. And of course, the clinical assessment of a patient that comes with seizures, it depends on two aspects. First, does the patient present in the acute or emergency setting? And that will be dealing with management of status epilepticus. And this is kind of a different topic from our lecture today. However, it's very important that all medical students know and master the approach and management of patients with status epilepticus. And it's generally really simple and easy and straightforward. And you can always refer to your institution's protocols. Most of the institutions have specific protocols for children and adults who present in status epilepticus. However, I will concentrate today on the management in the chronic setting, in the outpatient setting. So, of course, as I mentioned, the clinical assessment starts, of course, with history, examination, and then some patients require investigations, and of course, finally, we move into the management or treatment. So in the history, of course, history is really key in the diagnosis of any patient with seizures or epilepsy. And actually, in many cases, the only thing you know is history. The examination may be normal, investigations may not be revealing, so you are left to rely mainly on your clinical or historical data. Of course, many times we ask the parents to describe what happened. So you're also getting second-hand information, not directly from the patient, because the patient may not remember. The parents are not with the child all the time. So again, some of the data may be missing. However, one useful trick is to ask the parents to videotape the events. So particularly if you are not sure or confident of the description, and most of the parents, they now have a camera in their pockets, in their mobile, and that will be really quite easy and quite useful for you for the diagnosis. But in general, the history is classified into two divisions. First, history of the presenting event or the seizure itself, and that is typically subdivided into 4 components. So you would need to ask what happened before the seizure, what happened at the onset or at the beginning, what happened during the seizure, and do not forget what happened after the seizure or the post-ictal phase. So what happened before is what we talked about earlier, which is the triggers. Was the child febrile? Did he fall? Did he take a medication? If he's non-epileptic, did he miss his medications? Was he vomiting? And so on. So you look for any triggers. What happened at the beginning of the seizure or the onset is also what we mentioned earlier, is the aura. So if you have an aura, that will put your seizure into the partial category plus minus secondary generalization. The third component is what happened during the seizures, and most of the medical students, they know that part very well, but they may miss the other parts. So during the seizure, of course, the duration, color change, motor phenomena, loss of awareness, tongue biting, sphincteric control loss, and so on. Then finally, what happened after the seizure, which is the post-ictal phase, and be aware that sometimes the parents, they include the post-ictal deep sleep into the duration of the seizure. And you need to make that distinction very clear, because the mother will come and say the seizure was 20 minutes. And upon detailed questioning, you find that the seizure was only 1 or 2 minutes, and the remainder of the period was really just post-ictal sleep, and the mother could not wake up the child and thought that he was still seizing or abnormal. And that will make a difference, because a short seizure, we approach it and manage it different from status epilepticus. So in the post-ictal phase, you want to know what happened. Is the child awake? Is he asleep? I think if there is post-ictal sleep, that will help you confirm that actually a seizure has happened. Keeping in mind that some seizures has no post-ictal phase, like absence seizures or simple partial seizures, there should not be any post-ictal phase. If the seizure was partial and there is a post-ictal phase, that will make it most likely complex partial rather than simple partial. Some patients, they have focal neurological disturbances post-ictally, such as post-ictal headache, post-ictal weakness, post-ictal homonymous visual field defect, and these will help in lateralizing the seizure. Lateralizing meaning help you identify which side it came from. So if you have a headache, generally the headache is ipsilateral. But if there is weakness, most likely the seizure is contralateral to the side of the weakness. Next part of the history, of course, is the remainder of the history. However, keep in mind that some patients may have more than one seizure type. So the parents may only become alarmed and anxious about the big seizures, the generalized seizures. But you need to specifically ask the parents if the patient has other seizure types, because it's not uncommon that we encounter patients with multiple seizure types. And if the patient has more than one seizure type, you need to identify what do they look the same, description that we described earlier. and how frequent are they. And this is important when we come to the management, because a patient, for example, with juvenile myoclonic epilepsy may have generalized tonic-clonic seizures, but he may also have myoclonic jerks upon awakening. And if you give such a patient a drug like carbamazepine, the generalized seizures will go away, however, the myoclonus will get worse. Therefore, it is important to ask if the patient has more than one seizure type. The last part of the history about the seizures themselves is the evolution. So you see the patient in a given period of time. Say the patient is having 2 seizures per week. So if the patient has 2 seizures per week, this could be good or could be bad. We need to know what is that in relation to his usual seizures. For example, 2 seizures a week can be bad if he had only 1 seizure every 2-3 months before that. So the patient is getting worse. Or it could be good because he used to have daily seizures, and now it is only 2 seizures per week, so that is considered good or improvement. And that's what we call seizure evolution, and that will help. So you do not take the fact just as a kind of a spot data in time. The remainder of the history, of course, is important, particularly stressing past medical history, drug history, developmental history, neurological history, detailed neurological history, and of course family and social history. And I think the medical students, they know how to take the history very well, and I think you understand the importance of each part of this history in relation to the seizures, because a patient with seizure may have the underlying cause of the seizure, may cause developmental problems, may cause behavioral problems, may be identified in the history, maybe it's prenatal, natal, or postnatal, and there may be familial tendency to it. Next part of my talk will be the clinical examination. So in terms of the clinical examination, as I mentioned earlier, you think of the clinical examination in the acute setting, in the ER, in patients with status epilepticus, and I already mentioned that this is a different topic, but you do need to go over it, because patients who present in status or actively seizing in the ER, it's very important to make sure you're not dealing with 3 main issues. 1 is trauma, 2 is infection, meningitis, encephalitis, and 3 is toxic metabolic. So the examination may help you differentiate. However, we're talking about epilepsy. A patient comes in the clinic setting or the inpatient ward. Many times the clinical examination is unrevealing. However, there are important areas that need to be stressed. For example, in the general examination, it's important to get the measurements of the patient. You plot them on the percentile charts, so head, height, weight, and of course these are all important. You need to examine the patient's skin to make sure you're not dealing with any kind of neurocutaneous syndrome such as tuberous sclerosis or neurofibromatosis, which predispose the patient to seizures. You need to examine the skull, and the skull particularly in babies, feeling the fontanelle, feeling the sutures. Then examine, of course, the spine for patients with spina bifida who may have hydrocephalus. And of course, examine the patient neurologically in details, looking for any focal neurological manifestations. For example, patients with cerebral palsy or developmental problems may have. Just one final point in the general examination is the examination of dysmorphic features. So if a patient is syndromic or have an underlying genetic malformation, may have some dysmorphology. Example is Down syndrome, for example. Patients with Down syndrome are predisposed to epilepsy. Sometimes in the clinic, it is useful to perform a maneuver called hyperventilation. And hyperventilation is asking the patient to breathe fast, inhale and exhale quickly. And this maneuver should be performed for 3 minutes. And if done properly by the child, it can trigger absence seizures. And in that situation, that's all what you need to do. You do not need to perform any other investigations because you would have witnessed the attack in front of you. Next, we move to the diagnosis and investigations. And of course, again, just like I mentioned earlier, dealing with a patient in an acute setting is different from dealing with a patient in a chronic setting. So in an acute setting, as I mentioned earlier, you want to make sure you're not dealing with some kind of infection, you're not dealing with trauma, you're not dealing with intoxication, toxic metabolic, so many times you need to check the glucose, you need to check the electrolytes. However, if the patient comes to you in the clinic and he is well, and had recurrent unprovoked seizures, if no blood work was ever done, you should do some baseline blood work, particularly electrolyte. You don't want to miss an underlying chronic renal failure, particularly calcium profile. You don't want to miss vitamin D deficiency. But you do not really need to do a lot of other blood tests, like CBC will be useless unless the patient is febrile and so forth. So just basic blood work to make sure you're not dealing with any kind of disease or a disorder that predispose patients to seizures. Other investigations that we frequently perform is the EEG and the neuroimaging. And in general, if you have a patient who presents with recurrent unprovoked seizures, in general, an EEG or electroencephalogram is indicated. And the EEG, of course, patients with epilepsy may have normal EEG. Actually, up to 20 or 30% of patients with epilepsy may have a normal EEG. And that's simply because of the fact that the EEG is done interictally or in between the attacks. If you have an ictal EEG, of course, the sensitivity will be much higher. But in most of the situations, we do the EEG when the seizure already has occurred. However, the EEG is still very useful, and if it is abnormal, it confirms your clinical impression. If it is normal, it does not rule epilepsy out. So you still depend on your history, observation, and other data. However, if the EEG is abnormal, it is confirmatory. If the EEG is abnormal, it can also give you additional useful information. The EEG can help you in classifying the seizure, so you focal versus generalized, can help you in lateralizing the seizure, it's coming from which side, the left or right. It can help you in localizing the seizure, so it's coming from which lobe, is it frontal, temporal, parietal, occipital. The EEG also can help in identifying epilepsy syndromes, because some epilepsy syndromes have specific EEG abnormality, such as just the example I mentioned in the exam, the absence. They typically have generalized 3 Hz spike wave discharge or 3 cycle per second spike and wave discharge. Finally, the EEG also can help us with identifying response to treatment. So particularly in patients with absence or even patients with infantile spasms who typically have hypsarrhythmia. So you treat such a patient, then you repeat the EEG, you want to make sure that the EEG is not hypsarrhythmic anymore. So In other words, identifying response to treatment. Finally, neuroimaging again is indicated, particularly if the seizure was partial. If you have primary generalized seizure and the patient is neurologically and developmentally normal, you really do not need neuroimaging. Neuroimaging is indicated if the patient has neurological abnormalities, whether that focal or diffuse cognitive or motor, or if the seizure is partial, whether partial per se or secondarily generalized. Because in that situation, you worry about focal brain pathology. So if the seizure is partial, the importance of imaging is higher. Do not waste your time with doing brain CT. CT can be quite useful in the emergency setting to exclude major intracranial catastrophes such as hemorrhage, bleeding, stroke, trauma, and so on. However, CT is not very useful to look at the cortex in more details. So if you have the choice, MRI is superior to CT. But if you are worried and you're seeing the patient in an acute setting, or the patient has evolving or changing neurological status, you could get an urgent CT to exclude major intracranial catastrophe. However, MRI is superior. Other investigations, of course, will depend on the case and the underlying suspected cause. For example, some babies we do torch screen if we suspect prenatal infection, and so on. Now we move, before we talk about the management, I would like just to mention a few words about the differential diagnosis. When you see patients with seizures, of course, the differential diagnosis is more or less like the etiology, primary, secondary, post, and so on. However, when we talk about epilepsy, there is a number of non-epileptic events that can be confused with seizures, and each one of them will need a kind of a lecture to talk about it in details. However, I would advise you all to just go and read a little bit about each one of them, because they are peculiar, and in general they are at times more common than seizures themselves. And I'll just give you some examples. For example, in the neonate, tremulousness or jitterness comes in the differential. There is something called benign sleep myoclonus, quite common in babies when they fall asleep, and both these are benign. As the child grows a little bit older, there is something called excessive startle or hyperexplexia, where the child startle easily. Then, of course, breath holding spells come into the differential, breath holding spells. Keep in mind that epilepsy are always random, so you cannot predict when the seizure would happen. And in many of these differential, the mother or the father would predict when the event is going to happen, because it's related to sleep, it's related to upset, it's related to trauma, whatever. And that should raise the suspicion when it happens that it may in fact not be epileptic. So breath holding spells. Some patients may have pseudo seizures. Then as they grow older, of course, pre-syncope and syncope is in the differential, which is completely different than seizures. Then we move into the management, and as I mentioned earlier, the management, of course, we have the management in the acute setting, so management of status epilepticus, and the student should refer to the hospital protocol for that, because most hospitals, they have a specific protocol with the drugs that are available in that specific institution. For example, we use Valium commonly. In other hospitals, Valium or diazepam may not be available, and they use, for example, lorazepam or Ativan. In other hospitals, they may have midazolam, whether buccal or nasal midazolam, just as an example. So it's nice to know what medications you have, because they are kind of more or less equivalent. But in general, we go benzodiazepine and then another dose, and then we move generally to phenytoin before we move to phenobarb. Because once you add phenobarb after giving several doses of benzodiazepines, the likelihood of respiratory depression and hypotension becomes high, and the patient may require intensive care management. So in general, it's advisable to start phenytoin load before giving phenobarb. Also, another point is that patients, when you give phenobarb, you more or less lose your physical examination. So if you want to monitor the patient will be heavily sedated and asleep for 24 hours. However, if you give phenytoin, you kind of avoid that. And for these three main reasons, it's generally recommended to load with phenytoin before you load with phenobarbital. However, in the outpatient setting, the management, of course, depends on the findings on history and examination and investigations. So a given patient, you may identify that the seizure is, for example, you suspect it is due to vitamin D deficiency. You examine the child, you find features, you do the investigations. Then the treatment is not anti-epileptic drugs, is treating the underlying cause. So if you have a treatable underlying cause, then that will be the treatment. For example, if imaging showed the patient has hydrocephalus, then shunting will be the treatment of choice, and so on. So if you're identifying an underlying cause, then that should be treated. Also, one should keep in mind that there are comorbidities and that the underlying cause of the seizure may have other associated manifestations. So a patient may present with seizures, but he may also have, for example, motor difficulties, mental difficulties or mental retardation, behavioral change, learning difficulties, because there is an electrical cortical abnormality, and the patient may have other features of cortical insult. And this is important when you select medications. So if the child is hyperactive, you don't want to give him a drug that will make the hyperactivity worse. If the child is sleepy and drowsy, you don't want to give him a strong sedative, a drug that has strong sedation, and so on. So knowing these comorbidities is important in the management in order to address them and in order not to make them worse when you treat the seizures. We should never forget, of course, the value of education and telling the parents and instructing them what to do in acute situation, activity of daily living, for example, bathing, biking, swimming. And for that, we generally have or should have an information package that we give the parents in order, or a book to read about it. And here at King Abdulaziz University Hospital, we do have a 50 question answer format booklet that is available online, and we refer all the parents to it to read it in order not to go into mispractice or doing harmful maneuvers like doing CPR or mouth-to-mouth resuscitation or inserting objects in the mouth of the child during the seizure and so on. Then we move into the management, and of course, generally in my lecture with the medical students, I do not go into the details, the theoretical details of the medications, because these can be read in any kind of book. But in general, the medical student should know the acute medications. If you know, the more details you know about them, the better. So generally, read about benzodiazepines, particularly diazepam. Know the differences between diazepam and lorazepam, because lorazepam is kind of longer acting and may have advantages over diazepam. And know about phenobarb and phenytoin and know the doses. Generally, both they are 20 milligram per kilo. Know a little bit about the side effects. In the chronic setting, you should know about carbamazepine and valproic acid. Carbamazepine is generally used first line for partial seizures, valproate for generalized seizures. The medical student also should know a little bit about the newer anti-epileptic drugs, particularly 3 drugs. A drug called topiramate or Topamax, a drug called lamotrigine or Lamictal, and a drug called levetiracetam or Keppra, because these are the 3 newer anti-epileptic drugs that we frequently use. However, I'm just going to go over some principles of management quickly. First of all, when you start a drug, you want to select a drug that is effective for the seizure type. So you choose a drug that is effective for the patient's seizures. Second concept is you use a traditional anti-epileptic drug. We generally do not start with newer anti-epileptic drugs. 3, the concept of monotherapy. We never start more than 1 drug at once. We always start with 1 drug. 4, we target a low medium dose range. Most of the drugs, you can calculate the dose and there is a range. You do not aim for the high dose. You aim for the low medium dose range. 5, you titrate. So most of our medications, they are better tolerated if you calculate the dose and then titrate it over a couple of weeks. So you do not start it at once. But for example, you calculate 15 milligram per kilo per day of carbamazepine. You give half that once a day for 1 week. Then after 1 week, you make it BID. We call that titration. That will make your patient tolerate the medication better. These are the general principles. And then, of course, if the patient develops seizures, you may need to check the level, you may need to check the compliance, you could push the drug. However, if you keep on pushing the drug and the patient does not respond, go back and look at the history and look at the story again, because maybe you have something wrong. Maybe the patient does not have seizures or have one of the non-epileptic paroxysmal events, or maybe the drug you're using is not good for that seizure type, or maybe the compliance is not good. So just don't keep on adding drugs before going back and checking that everything is in check.